they do that, they have to suppress the immune system of the host. So if I'm the host, I will have to receive immunosuppressants because it's necessary so that if I receive the cell, the tissue, or the solid organ, my immune system will be unable to kill it because once I receive any foreign body, what will my immune system do to that foreign body?
Attack it.
All right, attack, send B lymphocytes and T lymphocytes to kill it. So therefore, to prevent that, because this is not really intended as a invader, right? It's beneficial to the patient, to the host. However, the body doesn't know that. All they know is that is a foreign object. We do not recognize that cell, that tissue, or that organ, so we will attack it. That's the reason for immunosuppression. However, um, in the case of, let's say, lupus, leukemia, or whatever other reason that we are doing the bone marrow transplant for, will it do any good if we transplant bone marrow from from a healthy person to a sick patient who has cancerous stem cells or cancerous bone marrow inside them? Will it make sense to do that?
No. Wouldn't the cancer just infiltrate the good bone marrow?
Exactly. So we can't do that procedure right away. So coming from the, so let's look at two patients here. So the host will have to be treated for leukemia first, meaning before we can put healthy bone marrow or healthy stem cells in there, we have to remove the old ones and the cancerous ones first. Now, the removal part would either be a combination of uh, strong chemo or high dose radiation, or both. So we will eradicate the patient's entire bone marrow because, again, the reason is it doesn't make sense putting healthy marrow in there with cancerous bone marrow still inside there, because it will, just like you said, it will just simply um, box out the healthy ones because the leukemic or the cancerous bone marrow are rapidly dividing way faster than any normal bone marrow. So therefore, we will have to treat the patient first. So therefore, if someone is receiving high dose chemo, high dose radiation, how do you describe their immune system?
It's low.
Very low. Now, this is the crucial part. When you put bone marrow from someone else into this patient now with the goal of, replacing the old bone marrow, which you have now eradicated, what if there were some active lymphocytes from the donor, okay, from the graft that was transplanted at the same time? What could happen to the patient? Meaning the patient's own immune system is gone because we eradicated it with chemo and radiation. So the patient here is totally helpless. And now here comes bone marrow that you transplanted, but it just happened to contain a few lymphocytes coming from the donor, which we did not intend. Accidentally we transplanted a few also. What could happen to the patient, to the host?
I'm going to reject the implant.
Well, they still able to reject it when we have totally eradicated your immune system?
Oh no.
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 However, the graft contained viable lymphocytes. So who's going to attack who now?
So wouldn't the lymphocytes from the donor attack the host?
Okay, so this will be the opposite of organ rejection. In ordinary regular rejection, it is the host that's attacking the graft, correct? That's why we suppress them. However, in this case, in the case of bone marrow transplantation, it will now be the host that will be attacked by the graft. So we call this now graft versus host disease. So it's the other way around. So it's no longer called rejection because the host is not the one attacking the graft. This time it will now be the graft attacking the host, which could cause death. Right? So before we go do that, let's do the procedures first. This is testable. So how do you prepare both the patient and the donor? So they'll have the same preparation because it's the same procedure. The only difference is you're taking out bone marrow from one patient, and then for the recipient or the host, you're putting it in. So they're undergoing the same procedure. So they'll have um, for the donor first. So there will be preparation. So yes, that's for bleeding because the site here will be the posterior iliac crest, posterior superior iliac crest. So that's right here in your love handle. Okay, if you feel the pelvis there, that's the site. So feel that and then think about how are we going to get the bone marrow out from the pelvis. So that will involve a really long needle, a big one, and we will have to pour, so we'll have to screw that needle into the bone to reach the bone marrow. So does that sound painful?
Very.
Okay, very. So the patient will receive anesthesia, both local or regional if necessary. And then here comes the drilling. Okay, so well, there's not literally a drill, but the doctor will be screwing the needle into the bone marrow, so the patient will feel a lot of pressure. Even if you eliminate the pain with anesthesia, the patient still, the donor will still feel the coring. Okay, so during screwing the large needle in there. And then of course, once we get our bone marrow, we take out the needle. Will there be possibly bleeding?
Yes. Yes.
Okay, there will
Yes.
be bleeding. So therefore, how will you position the patient after it? So just read the procedure. So here we are now. So
Do we position prone, Professor?
Let's read it here. So
okay.
you tell them that there's pressure, right? Pulling and screwing. Okay, as we're getting the bone marrow, and then so the procedure will take about 10 minutes. Now, post procedure, how do we position? Thank you for reading, Arena.
Where are we reading? Explain to the patient. Okay, if the insertion site is the posterior iliac crest, assist the patient into the prone or lateral decubitus position. If the sample is taken from the sternum or anterior iliac crest, the patient will be supine.
Okay, that's clear, right?
Yeah, thank you.
Okay, so that's for, well, just imagine that this is either the host or the donor, right? Because the procedure will be the same. The only difference is in the other one, we are taking the bone marrow out, for the other one, we are putting it in, but the same procedure. So here's the size of the needle. That's quite big, right? So if it's posterior, the patient will be on their belly, right? So will do the prone position post procedure. Then of course, if it's anterior, then so this is the posterior, that's the anterior. So we will put the patient supine if it's anterior. And here are your post procedure. So bleeding is a concern, so make sure you apply pressure on the site. okay, for at least 5 to 10 minutes or longer if necessary. And that's it. Any question about? But the danger here will be on the host, on the recipient, because remember, we had to eradicate their entire bone marrow before we perform this procedure. Right, so the patient received high doses of chemo, high dose radiation, so they are extremely at risk for infection here. And so therefore, watch them for possible graft versus host disease, although the doctors will do their best in order to make sure the lab removed all possible active lymphocytes there from the bone marrow, that it's only going to contain stem cells, right? No active lymphocytes. So they'll wash the sample, making sure it's free of that. That way we prevent graft versus host disease. And that's it. Any questions before I go to thermoregulation? Thermoregulation will be hyper or hypothermia conditions. So let's go with 1990. Okay, still related to transplants now. All right, there are 3 types of rejection with transplant. So this one is in page 1391. This is kidney. So let's use the kidney as an example. All right, so we have hyperacute rejection. This will occur within minutes, meaning this could possibly occur during surgery, meaning as soon as let me illustrate. So here is the old kidneys. Okay, so the patient had end-stage kidney disease and they've been on dialysis, right? So now they get a kidney from a donor. So they put the donated kidney inside the pelvis. So this is your pelvic bone right here. So they insert it here. So they move the intestines, the bowels, to the side, and then insert this in the pocket inside the pelvis. And then instead of messing with these large renal veins and arteries, they'll leave that alone. They'll use the iliac instead. So they'll use they'll connect the donor's renal vein and artery to the iliac, the host iliac arteries instead. So this is the most safest way to do it, because if you cut these out, these are larger vessels here, so you're dealing with a lot of bleeding. Plus, it's easier to just put the kidneys here, because there's no way for this to be suspended there anyway. Because remember, the old kidneys, these are connected to by connective tissue. That's why they stay there. So this one doesn't have that. So it's really better if you put this thing here. So as soon as because they'll be clamping these vessels here as they attach them. So as soon as they remove the clamps and then blood flows into this kidney, if it's a hyperacute rejection, it occurs right there. So immediately during surgery, or it could also occur up to 4 days after the transplant. Okay, so that's hyperacute rejection. The reason for this is it's a problem with antigen-antibody interaction, meaning this is quite rare because we did matching, right? And then we suppressed both the donor and the recipient. If it's a living donor, we already immunosuppressed both. That way we have the least amount of lymphocytes there or white blood cells, okay, when we perform the transplant. However, this is just a freak wherein we did our best, but then somehow it still resulted in clot formation. So the reason for hyperacute rejection is there will be micro thrombi forming all throughout the graft, occluding every capillary, every artery, every vein inside that graft. And so, of course, that will cause immediate failure of the organ because it can't perfuse anymore because it's all clogged. So no perfusion, the graft dies or fails, and then all you can do is take it back out. No, too bad it didn't work. But it is very rare. Okay, hyperacute rejection is probably 1 in a million, okay, or maybe less than that. Acute rejection is the most common. So when does this thing occur? It occurs first during the first 3 months after the transplant. However, you will not have only one episode of acute rejection. It will happen again and again and again and again and again and again and again. So throughout the life of the graft, this will be constantly happening. So every few months, every few years, it will occur again and again. The reason for this is because of cytotoxic or cytolytic action, meaning it's caused by the lymphocytes. I know we suppress the patient, we suppress the host, we gave them immunosuppressant therapy. However, the host immune system just found a way to increase production of lymphocytes somehow. You know the saying, what doesn't kill you makes you stronger? So that's what's happening here. So even though you tried to suppress the host immune system, it found a way to increase production somehow. Now, this type of rejection doesn't necessarily mean the end of the graft. You can still save it by increasing the doses as stated here. Increased doses of immunosuppressive medications are used to manage episodes of acute rejection. So here, every time it happens, because it happens all of a sudden, so you can see the symptoms right away, which is good. They can be observed. The patient's blood pressure suddenly shoots out. For here, for instance, the patients will have fever, swelling, or tenderness over the site. Then the urine output drops, so that's oliguria, and then your creatinine levels rise. So you can see it, which is good actually, because you can observe the rejection happening. And what the doctor will do is increase the doses or add more medications. And again, it won't happen just once. So this will happen again and again all throughout the patient's life. However, the third type, so that is acute rejection. The acute rejection, the reason again is cytotoxic activity of the lymphocytes. Okay, unlike hyperacute, wherein you had clotting, right? So hyperacute was caused by widespread clotting. Acute rejection is caused by cytotoxic activity. Your T lymphocytes are attacking the graft. Chronic rejection is not as easily managed, because here the problem here is the cause here is chronic inflammation and scarring. So because the graft is a foreign body, it will cause inflammation to some extent, because let's say I put Sabine, if I put a piece of needle inside your arm and then push it in, then you can't see the needle, but it's inside your body, it's under your skin. What will happen to that area of your body eventually? Because you have a needle stuck in there. Ms. Legros? Or who's still here?
It's gonna cause inflammation.
Okay, so there will be inflammation, right? So the same thing will happen here. If you have a foreign body lodged in there, you have a kidney from another person inside you, so that will cause some extent of inflammation around the area. Even if you're taking immunosuppressants, you're taking anti-inflammatory medications, there will still be some inflammation in the area nonetheless, because you can't really 100% suppress your immune system. Okay, so only those specific cells that are involved in organ rejection. So as a result of this chronic inflammation, it will cause, of course, whenever there's something inflamed, there will be thickening and enlarging of the vessels, right? So when these vessels, in one section first, one small part of the graft becomes swollen, and then it therefore narrows the lumen, so there will be less blood flow to that area. And then some parts of that graft dies and then becomes scar tissue. But again, no big deal, because these things happen so slow. So think of it as the graft dying and then replaced by scar tissue, small parts at a time. No, it doesn't happen as a whole like in acute rejection, where the entire organ is attacked. So here, the inflammation and scarring occurs slowly over several months, several years. So therefore, your manifestations are not the same as acute, wherein you can see it develop right away. So here in chronic rejection, these are your manifestations for. So for in a kidney, there'll be progressive azotemia, meaning progressive increase in your BUN creatinine. There'll also be progressive proteinuria and progressive hypertension. Can we stop this? Not really. You can slow it down, but you cannot stop it. So here, the management will be the same as what we did in acute rejection. The doctor will prescribe higher doses of the medication, or even add steroids, add prednisone or other corticosteroids. However, think of chronic rejection as the patient developing chronic kidney disease again. Remember CKD from NUR 241? Yes? No? Maybe?
Yeah.
Okay, so how did CKD develop? Was it fast, or was it gradual and subtle?
Gradual.
Yeah, it was gradual, it was subtle, it was progressive. Okay, so think about it as what's happening here. So chronic rejection is so slow, just like developing CKD. Again, you can slow it down, but you can't really stop it. Okay, there's no way to stop it. So chronic rejection is eventually the patient will lose that graft again. Any questions? All right, let's go now to the drug therapy. So what drugs are used for preventing organ rejection?
Immunosuppressant.
Yes, okay, let's go now to the drug therapy. I think it's 370.
What page, Professor? 375?
I'm looking.
Oh, okay.
Yes, okay, 375. The drug should be here under medical management. Okay, I remember now. The under 375, the nursing care is here. Any patient receiving immunosuppressants, like the patient who received a solid organ transplant and is taking immunosuppressants, this is your nursing care. So these are the assessments you do and your actions. So you protect them from infection. Remember, you are suppressing the patient's immune response, so they will not be able to protect themselves from ordinary infections. So they are prone to opportunistic infections, common colds, the flu, so they are at high risk. These patients must receive regular vaccinations. There are also candidates for pneumonia vaccination, So since one thing to remember is, as far as temperature goes, do we need to wait for a high temperature before we consider?
No, because they are so immunosuppressed.
All right, so a low-grade fever in these patients, like 100, for instance, because fever doesn't start at 100.4, correct? So these patients, they reach 100, that's already a sign of infection for these persons. All right, so that's something to keep in mind. So they need to do hygiene. Okay, so when we say hand washing here, you can go beyond hands. Okay, so what are other body areas that are frequently dirty for you and me?
Vaginal?
Okay, the perineal area,
Perineal,
right?
yeah.
So around our genitals and the anal region. So these have to be washed regularly, at least twice a day. Other areas are the underarms also. So underarms, the groin, these are dark, moist, warm places wherein bacteria would like to grow and thrive. So you need to keep those areas clean. They should be instructed to wash them at least twice a day. And avoid crowds. Do not change cat litter boxes or have reptiles. Okay, they carry salmonella. Your diet must not contain anything uncooked, so they can't eat fruits and vegetables, especially strawberries or blackberries, because those things have ridges. You can't really wash them carefully. Other fruits might be okay, but try to avoid um, anything uncooked. Right, so salads would be out of the question. Subway sandwiches, the deli, they can't have those. Sushi, none. All right, because they are so immunosuppressed. So the one bacteria you eat, may be enough to get you sick. Right, so anything uncooked or undercooked. So here's the temperature. Report if they have a cough, because that's already, we want to treat it early. Upper respiratory infections can easily progress to pneumonia, because again, you have your normal flora here are also decreased in number. So watch for urinary tract infections, and if you have any wounds, they should be monitored as well. Here are the medications. So these are the common ones used for immunosuppression as far as organ rejection is concerned. So you can call these drugs as anti-rejection medications. So we have cyclosporin, mycophenolate, and azathioprine. You don't have detailed side effects here, so I guess I'll just use the names and then test you on your nursing care, right? Because your book did not specify the side effects, but because let's say you get it on the NCLEX, it will be. So what do you think you will develop if you are suppressing your T lymphocytes, for instance, your natural killer cells? So if those are suppressed, like here, your helper T cells are blocked, your B cells, which are your intelligence. Okay, if this was the military, the B cells are the intelligence officers, and the T cells are like the Marines. Okay, these are the special forces. These are the actual soldiers here. And then this one, look at this. This disrupts DNA, RNA. Therefore, they prevent the division and multiplication of your B and T lymphocytes. Okay, so overall, these drugs therefore block the production and stimulation of your lymphocyte growth and maturation. Right? So
bone marrow production.
Yeah, so therefore, what will be your patient's side effects here? Because take azathioprine, for example. Does this drug only disrupt DNA and RNA synthesis in the bone marrow? Will they only do that? No.
No.
Yeah, DNA and RNA synthesis in all your entire body. So therefore, will you have GI problems here? Because GI tract cells are also rapidly dividing. So you'll have, yeah, GI complications. So you have nausea, vomiting, diarrhea. But your most important concern here is it will cause bone marrow suppression, right? Because the bone marrow is the one producing your white blood cells. And therefore, since the bone marrow is also producing red blood cells and platelets, so will the patient have anemia?
Yes.
Yes.
They have thrombocytopenia.
Yes.
Yes.
Leukopenia.
All right. So you take all those into consideration. Okay. So even though it's not literally written here, so you can imply that that's what's going to happen, right, to the patient. So since especially this drug, since that's what it does, so we call this a anti-proliferative. So it sounds like a chemo drug, right?
Mhm.
That's what chemo drugs do. So azathioprine can be used for chemo. Same for cyclosporin and mycophenolate. The cheapest one among here is mycophenolate. This one is frequently used. Most patients who receive transplants are on mycophenolate. It's the most cost-effective drug.
Professor, these are the same drugs for lupus.
For
right?
lupus.
Yeah, the same thing, because if you think about it, lupus are autoimmune disorders, right?
Okay.
Yes.
Okay.
Yeah. So lupus,
Yeah.
multiple sclerosis, Crohn's disease, psoriasis, patients take the same drugs.
Oh wow. Okay. Thank you.
All right. So the concept will be really the same. So anytime you want to suppress the patient's immune response, which includes autoimmune disorders like rheumatoid arthritis, even although we don't give these for rheumatoid arthritis, we use something else like methotrexate, which is more specific to the particular cytokine, because we don't really want to suppress just everything, right? We have to be smart about this because we want to lessen the side effects as much as possible. So let's say you've probably seen commercials on TV, like adalimumab, for instance, Humira.
Yes.
That's the most popular drug there for psoriasis and also rheumatoid arthritis. So yeah, they're very cell specific, meaning they won't suppress the entire immune system, but only specific cytokines. Any question on immune concept? So we discussed the transplant rejections and the drug therapy, as well as the bone marrow transplant procedure and nursing care. Any questions?
Professor,
Yes.
as far as the teaching goes, couldn't you, I know it's not listed, but I guess of a common sense, couldn't you also teach the patient to avoid travel, outside the country if they're immunosuppressed?
Yeah,
or not
because
necessarily.
well, that would be implied, because when you travel, you have to get on a plane, which
Right.
is which is crowded. So that would be implied here. Avoid crowds or large gatherings, which is a plane.
Okay.
Yeah. Or even if they travel by ship, no, it's still crowded and a large gathering. Yeah.
Okay.
I'm sorry. Wait, they're not allowed to fly.
I mean, it says here avoid crowds. So unless they fly, they can charter a plane, then yeah.
Can
Or
I
if
ask, is that realistic? Do patients, comply to this, rule or, the suggestion not to fly? Do patients comply with that?
Say again the first part.
Sorry, do patients comply with that sort of thing? Not flying and because it's really hard. Some of these things are I don't
Okay.
know.
All right. So take for instance your life before the transplant. Okay. So let's say you lost your kidneys and you got a kidney transplant. So before this, you were on dialysis 3 days a week for I don't know how long. So do you think you will not comply, thinking that your life will go back to dialysis, which makes travel even worse?
But okay, so even for like lupus though,
Uh-huh.
it's the same, it's a similar teaching.
Yeah, exactly. So if you pretty much if you value your life, yes, you will comply. I mean it's a free country, but if you
So
know if you
patients do comply with this.
yeah, you have to.
Okay. I was just curious if maybe, like, I don't know. Thank you, I guess.
Yeah, I mean these people experience life-threatening conditions. So this is actually a second lease on life. They got a new or well, not new, but they got a recycled organ. You know what I mean? So yeah, so these patients do value this new lease on life, so to say. So they will comply with these. Some of them may inadvertently, not know. But I mean, I know some students who have kids who have immunosuppressive disorders or are taking medications. So yeah, they're very protective of their children. I know a few moms that like almost eat you if you, let's say, touch their kid, or of course, they should have notified people, before they do that. Or let's say the kid goes to school, wearing a mask and all that. Any other question? All right, let's
No,
go.
thank you.
I believe we did this. 238 should be Guillain-Barré. Oh, we have more drugs here. Oh, here's the procedure. This would be under, you know what? We'll discuss this part under cancer, which is the next module. So I'll just hold off on this part because this is now talking about chemo and radiation to treat bone marrow cancers like myelomas, um, or multiple myelomas, or leukemia. All right, so we'll skip this part for the next module. Let's go to 354. Oh, we did lupus already. 808 should be the Guillain-Barré syndrome. Yeah. Okay. So let's go to 299. There's just one section here, which is malignant hyperthermia. So this is a complication of general anesthesia. It falls under thermoregulation problems, basically because this causes severe hyperthermia. All right, so this is an inherited disorder, genetic, preventable, generally speaking. This is part actually of your pre-op checklist. So when you're preparing a patient for surgery, especially general anesthesia, there will be a set of questions you ask to see the risk for malignant hyperthermia. It is fatal, but extremely rare. So what happens is this is going to cause a hypermetabolic state when exposed to anesthesia. So the inhaled general anesthetics here, namely isoflurane, desflurane, ensuflurane, halothane, pretty much almost all inhaled general anesthetics will trigger the disorder. So what happens is the patient has the gene, let's call it the malignant hyperthermia gene, which reacts when the patient is exposed to the anesthetic, or to this drug right here. Succinylcholine is a muscle paralyzer. So when someone is having major surgery, so when we put you on the operating table, we can't have you moving, because imagine someone, the doctor's in there, right? So let's say he's working on your heart. So your chest is open and he's delicately, carefully slicing stuff there, trying to do his best, and then you twitch and move. What could happen?
To the other
patient
area
moves during surgery. Yeah, so that can cause a disaster, right? You could cut a major coronary artery, for instance. So therefore, to avoid these accidents, the patient is paralyzed. So we give you succinylcholine, which is a muscle paralyzer. I mean, you're literally paralyzed. That's why you are intubated, because you can't breathe. Even your diaphragm is also paralyzed. So you're pretty much dead when we're operating on you. Okay, so without the ventilator, you can't breathe. So that's why when we expose you to this, we give you, paralyze you, and then we intubate you. All right, then we can safely do the surgery without you moving. So here, when exposed to these drugs here, the succinylcholine, which is your neuromuscular blocking agent or your muscle paralyzer, plus your or your gemflurane, desflurane, enflurane, halothane, they all sound the same. This will trigger a hypermetabolic state. So the skeletal muscles react to these drugs, causing a sustained muscular contraction. Now, imagine contracting your muscle. Gio, I don't know which muscle you want to contract right now, but try a set of muscles and don't look or muscles if you do this. So we'll wait until maybe one of the times. Sounds good? Gio, are you contracting anything?
Professor, I didn't hear you. You were cut.
Or Giselle?
Yeah, it's something with your internet, Professor. You're breaking out.
Okay, it is. All right, hold on. How about now?
Now we can see.
Mm-mm.
It's very laggy.
How about now? Can you hear me now?
No.
Now you have an echo.
Is it tolerable?
I think it's even worse now.
What do you want me to do?
Team is acting up to.
That's some crazy echo.
Like chickens.
How about now? How about now?
You're not clear.
Is this okay?
No.
Mm-mm.
Can you hear me?
No.
I mean, it's like you're breaking in, like.
I barely hear you. Like it's breaking.
No, so you can hear me.
No, you're breaking, like we hear you, but what you're saying, it's not like, it's like just breaking by the words.
Yeah, it comes in and out.
And there's a high pitch.
Oh my god.
Yeah, it's something like. brain attack with the sound.
Is this better?
No.
Maybe stop the
No.
video, but then we won't see the book.
Is better?
Now you're coming back,
Yeah, it looks like.
but there is some noise behind in the background.
There's major echo for me.
I don't hear it now.
That's much better.
Let me see if my son's laptop is free.
There's some feedback coming back. Like,
Yeah, my ears are starting to go.
It's like a very high pitched.
Yeah.
noise. Oh my god.
What is that?
Like somebody sitting.
It feels like I'm getting tinnitus.
Mark, you need a band to check on your ears.
Can you hear me now?
Yeah, I think like.
All right, so let's continue. If I start cutting out, please interrupt me again. Okay, so the triggering agent here is again the anesthetic and or the succinylcholine. So what happens is the skeletal muscles exposed to this will go into contraction, sustained muscular contraction. So if that happens, what will happen to your body temperature when your muscles contract and never stops or relaxes?
It goes up.
Go down.
Gonna go up.
Right, so
Go
temperature
up.
starts to rise. However, hyperthermia here, which can reach about 111 degrees, is actually a late sign. So the earlier signs here of malignant hyperthermia are the following, which are also the causes of death. So the hypermetabolism that results here will result in lactic acidosis. So if you have increased muscle contraction, will that increase oxygen demand?
Yes.
Will there be enough oxygen to meet that demand? No. So that's why it will cause tachycardia, because really you will become hypoxic, right? So there will be hypoxemia. When your oxygen levels goes down, what will happen to your carbon dioxide levels?
Goes up.
Okay, so this will explain it. So when your body is now in anaerobic metabolism, so just like in shock, because now you have oxygen debt, correct? Because your muscles are using up more oxygen than what's available. So that will cause lactic acidosis, tachycardia, hypercarbia, and here's the hypoxemia. Glycolysis will happen because of course your body is burning through a lot of glucose here because of the sustained muscle contractions. And then of course the late sign, which is hypothermia, can reach up to 111 degrees Fahrenheit. So imagine the heat there. So what will happen to your brain if we expose it to 111 degrees?
It's gonna be frying.
Right, so it'll be well done eggs. All right, so therefore you pick which one you want to die from. You want to die from acidosis, you want to die from hypoxia, you want to die from kidney injury, because on top, not mentioned here, what will happen, oh, it's actually mentioned here. So myoglobinuria, because now these muscles that are sustained, that are contracting in a sustained manner, they cannot relax. It's continuously contracting. So when you raise this patient's arm or leg, it will become very rigid. Okay, it's like the whole thing is stiff. So if you put this patient's arm up, it will stay up. You get the picture?
Mm-hmm.
All right. So this will of course cause muscle damage now. So muscle cells will start to die. Of course, that will lead to myoglobinuria. And what can happen to your kidneys if you put tons of myoglobin into it?
Kidney damage.
Right, it will cause, yeah, this is like rhabdomyolysis. If you remember rhabdo from, I don't know which semester you talk about rhabdo. So
Yes.
this is, there's muscle damage here. So it can cause acute kidney injury. So plus there will be, what else will the cells release besides, let's say you have skeletal muscles that die, besides uric acid, myoglobin, what else will they release? Potassium. So hyperkalemia is another cause of death here. So tell me which one you want to die from. Acute kidney injury, hyperkalemia, hyperuricemia, hypoxia, acidosis, or hyperthermia.
Which one is less painful?
Which one is
All
quicker?
of them will kill you. Who cares? What about the pain?
Maybe potassium.
You're dead
Whatever
anyway.
is less painful and more faster, I'll choose
Okay.
one.
But you see my point here that this is fatal,
Yeah.
right? So the patient will die. Plus, look at the scenario here. Because when does this occur? This can occur right after exposure to anesthesia, which is the best time because we haven't made the incision yet. However, it can also be a delayed reaction. What if it happens in the middle of surgery?
That's okay. Because you're going to be dead anyway.
Meaning, Gladys, we already have your guts out. We already opened your abdomen, already took out a couple things, and then at this time your bowels are out on a tray. It's inside a bowl while the doctor removes something. Let's say it's a exploratory laparotomy, a very major surgery, and then you decide to have malignant hyperthermia in the middle of all this.
Professor, you can't always know that, correct? Even though it's genetic, let's say maybe the family hasn't had like a surgery or some type of scenario like that.
We
You just
can
have to be like prepared, correct?
Okay, so let's go to the management shortly, but you see how this is dangerous, right?
Yeah.
Mm-hmm.
So before we go to management, let's do prevention first. So how could we have avoided this? We know it's a genetic disorder, so how do you assess the patient's risk for it?
History and maybe muscle biopsy if they had a history.
Okay, right here. So since it's a genetic disorder, all patients should be asked preoperatively if they or any family members have had problems with anesthesia. Whenever the answer is yes, it doesn't have to be specific. It doesn't have to be to say, yeah, my dad has malignant hyperthermia. Well, technically speaking, they won't know this because it's the parent or maybe it's the grandparent, and maybe the patient was never told that they had a malignant hyperthermia episode, right? Because remember, they were under the anesthesia, so they're unconscious the whole time. Okay, and then they don't bother. Yeah, they won't bother to read their hospital record now. Oh yeah, we by the way, during surgery you developed malignant hyperthermia, but you developed it early, so we were able to stop it. So chances are the patient will not be aware, right? So that would be a problem. We do not screen all patients for the risk for the gene because for one thing, the insurance won't pay for it. Plus, it's extremely rare. So the only effective prevention will be the questions we do before surgery. Okay, so we ask the patient, have you had general anesthesia before? No. have your family member, you know, your parent, a sibling, a grandparent have had general anesthesia before? And if they say yes, did they have any problems with it? So again, whenever the answer is yes, then the doctor should be notified that, and the anesthesiologist especially. So they'll be notified, hey, the answer was yes to this. So they can take precautions now. So they will avoid those drugs that are known to trigger malignant hyperthermia. Okay, and that is so far, that's our most effective way of prevention. Any questions before I proceed?
No.
All right, so the management wasn't really specified in this textbook. You only have this small box right here. So all your interventions are in this tiny little box. All right, it's a medical emergency. So the thing here is, since, what's the trigger again? What caused the reaction?
So phenylcholine and inhalation anesthesia.
All right, so just like blood transfusion, what do you do first?
Stop it.
All right, stop the inhalation anesthesia and stop the succinylcholine. There are alternatives, so you can use other drugs. So let's say the patient, this is in the middle of surgery, the anesthesiologist will switch drugs. So he'll use, because of course the patient still needs pain management, so, and they still need anesthesia. So he continues, but with another drug now. To manage the existing malignant hyperthermia, we have to stop it. This is the only FDA-approved drug, dantrolene. It is a muscle relaxant. You may have seen this also. Oh, wait a minute. We haven't done multiple sclerosis yet, right? This is also used in multiple sclerosis, but the dantrolene here obviously is IV. So this will stop the muscle contraction right away. However, since the muscle contraction did occur at one point, so we need to start cooling the patient now. Of course, the patient's already intubated, so the oxygen part, no problem, because the patient is already intubated, so we continue oxygenation. We give dantrolene, and then we start cooling the patient. The cooling here will be inside and outside. So we have internal and external cooling. External, no problem. We know about this. We remove blankets. We put ice on the patient or cooling blankets. Now we also cool the patient internally. So all the IV bags we will be giving will be wrapped in ice so that when they enter the patient's bloodstream, they are cold. We will also lavage the patient. So we'll put in a nasogastric tube and put in cold water inside the stomach. Suck it back out, put it back in, suck it back out. So that's called lavage. Okay, so we irrigate the stomach with cold water, and then we also suction it back out, and then do the same thing again. So we're here we're icing the patient's body. We're also cooling the patient's stomach. And if possible, also besides the stomach, we will also put a rectal tube and do the same thing. So we will put cold water into the rectum and then let it drain. Put cold water again, let it drain. Cold water, let it drain. So here we're literally cooling the patient internally and externally. Because imagine 111, how do you drop that if you just do external cooling, right? It's impossible. So cooling measures here will be internal and external. And hopefully this patient survives with no permanent kidney damage, no major organ damage because of the hypoxemia, and definitely the patients, this will go on the patient's record that they are allergic to anesthesia. Any question? So what are the early signs again? Remember, hyperthermia is a late sign, okay? The
Tachy.
high temperature here will be later. The earliest signs would be the following.
Tachycardia.
Yeah, the hypoxemia. So the anesthesiologist will see the oxygen level drop, followed by a rise in the CO2. He can see this because we have a CO2 detector in the patient's airway when we intubate. We'll discuss intubation later. So he can see the CO2 levels here as well as the oxygen level. So this would be his first cue that, you know, he'll tell the surgeon, hey, we have a problem here, right? And then we start managing the. There's a kit, by the way, so you don't have to worry. There's a kit in every OR. It'll be labeled malignant hyperthermia kit. So what do you think will be in that kit?
Dantrolene.
Number one, dantrolene. What else?
Insulin.
Did somebody say
Whatever.
insulin?
Yeah.
Yeah,
Yeah.
there will be insulin and glucose there. Yeah, for the hyperkalemia. What else? Will there be
Potassium.
saline bags there?
Potassium.
Yes.
No, we don't need potassium. The patient's potassium will be high here.
Okay.
We're trying to
No,
lower.
saline.
Yeah, we have saline, dantrolene, saline, insulin with dextrose. What else? Will there be ice in it?
Yes.
No.
No.
No, that's something you
How
can.
do you store?
We have the blanket, yes.
No, you can't have ice there.
But we need to put ice to for the ice with the IV fluids, no?
Now you just have to grab ice.
Okay.
Right? Okay, that's it. Let's take a break. Come back at 11 o'clock.
Okay.
Okay, thank you.